This podcast is not CME eligible. If people do want to learn more about CME eligible podcasts, Alex, what do they do?
They can go to jerrypal.org/CME.
And on to the show. Welcome to the Jerry Pal Podcast. This is Eric Woodrell.
This is Alex Smith.
And Alex, we've done now several episodes, I believe, on liver palliative care and liver disease. Today, we're going to be talking about a JAMA article titled Palliative Care Intervention for Patients with End-Stage Liver Disease, a cluster-randomized controlled trial, with three of its authors. Who do we have with us today?
We have Manisha Verma, who is an internist and researcher and director of research in the Department of Medicine at Thomas Jefferson University. Manisha, welcome to the Jerry Pal Podcast.
Thank you. Thank you for having us.
We have Chris Woodrell, who is a palliative care doctor and researcher and associate professor at the Icahn School of Medicine at Mount Sinai. Chris, welcome back to the Jerry Pal Podcast.
Hi, thank you.
And we have Marie Bakitas, who is a nurse researcher and is retired professor and associate director of the Center for Palliative and Supportive Care at the University of Alabama, Birmingham. Welcome back to Jerry Pal, Marie.
Hey.
So before we talk about this article and in general how we think about palliative care and liver disease, who has a song request for Alex? Manisha, is it you?
Yeah. So first of all, really thank you, Eric and Alex, for having us. The song request we have today is Slipping Through My Fingers by ABBA.
Why did you pick this song?
I felt this song is really resonating with what we have accomplished so far, and particularly the advisory board members. The study involved patients and caregivers. Those advisory board members really reflected on the passage of time, cherished relationships, and moments they wished to kind of be together. And above all, I really want to dedicate this to my father, who I really lost before I entered medical school. So it was a really tragic event, but his motivation, his passion, his way of living has really shaped me. So I really want to dedicate this to him because I'm sure he's very happy with the outcomes and where we are at this point in life. Thank you.
And are you an ABBA fan?
Not too much, but okay.
All right.
I think
But
this
the
might
song
be
is
the
really good.
first ABBA song in over 400 requests.
No way.
Yeah, congratulations, Manisha. I think you've hit upon a new artist that we haven't done before.
Thank you.
Here's a little bit. School bag in hand, she leaves home in the early morning, waving goodbye with an absent-minded smile. I watch her go with a surge of that well-known sadness, and I have to sit down for a while. The feeling that I'm losing her forever, and without really entering her world. I'm glad whenever I can share her laughter, that funny little girl. Slipping through my fingers all the time, I try to capture every minute, the feeling in it, slipping through my fingers all the time. Do I really see what's in her mind each time I think I'm close to knowing? She keeps on growing, slipping through my fingers all the time.
Wonderful. Now we got to have more ABBA on the podcast.
Sure.
Careful, dear listeners. Those are tough to play with solo guitar, but you can request. It'll probably sound a little different than the original. All right. Thank you. Thanks, Manisha.
Marie, Chris, are you either of you ABBA fans? Got a little Waterloo or
Casual ABBA fan.
casual ABBA fans?
I like Australia.
Okay. We'll have to have you back on. Well, we're not going to be talking about ABBA at this podcast. We're going to be talking about, really wanted to talk about the study that you did. So, Manisha, I'm going to turn to you. Why did you decide to do a study looking at palliative care specialists versus hepatologists trained in somewhat in palliative care? Why did you decide to do this study?
I think that takes me back to like 6 years ago when we proposed this study, right? You're like, why this study is the first important question for any grant application. So we really undertook this study despite really because I think the really important part is the symptom burden and the psychosocial challenges among patients with advanced liver diseases is under-recognized. There is lots of studies which have proven that there is a high burden among this population, but there are no, you would say, interventions which have addressed these. So there is limited evidence on palliative care in this population. So this is a chronic, complex, progressive illness where there are usually at the terminal stage, either it's death or a transplant. Now, transplant is not in your hand, organs are limited. So the decision making is very, very complex for this patient population. And despite clear evidence, we all know palliative care improves quality of life, improves symptom burden, improves decision making among many non-cancer serious illnesses. And why not liver? Why are these people getting delayed interventions? And above all, there's data that shows less than 10% of these patients receive palliative care, and that too within 6 hours of death. But that's futile. So we wanted to do an early intervention for this patient population and address some of the major barriers in current care, and design these two beautiful models and conducted a comparative effectiveness trial.
All right, I got a question. I'm going to turn to you, Maria, on this, just because you have a tremendous, both having done studies around palliative care and just an incredible knowledge about this. What are your thoughts? Like, if I go to a cardiologist, I don't have to see that a cardiologist has done that. We have randomized control studies of cardiology controlling atrial fibrillation, or cardiology in the management of heart failure, or cardiology in the management of even hypercholesterolemia. But we have patients go to cardiologists all the time for these things. Do we need randomized control trials of palliative care in condition X, like palliative care in this case, liver disease, or palliative care in different types of cancer, palliative care in ALS, palliative care in... What are your thoughts on that?
Yeah, I don't think we do, but guess what? We are not going to get those patients seen or those clinicians convinced unless the palliative care study is done in disease A, B, C, or and D. Because everyone turns around and says, well, just because it works in cancer, advanced liver disease is way different than cancer, although, HCC is part of that, right? So I think it's a matter of more convincing the clinicians who refer and the patients and caregivers who will benefit.
Do you agree with that, Chris?
Yeah. And I think we are having a conversation a lot as a field about palliative care versus usual care. In this case, that's not what was done. It's palliative care delivered by the specialist team or by hepatologists who received the module training, depending on what site you were at. I think that, in this case, everyone in the study received some sort of palliative care. And this was also an opportunity for Manisha and Victor Navarro, the PIs, to take part in that, palliative care call for applications that PCORI had done in, 2017?
A decade ago.
Can you imagine?
No, it looks like a decade. You're absolutely right. The study went through middle school and now high school and preparing for college. So I would just like to add that really the study was designed not to answer the question, does palliative care work? I mean, we all know it works. I think putting efforts into this question is just futile, probably. We already have substantial evidence on this part. The question we were trying to answer was very different. For patients with advanced liver disease, what is the best way to deliver it? That's why we compared these two active comparators.
And what were the two active comparators for? Because our listeners may have not read this study. What are the two active comparators?
So the two active comparators was treatment A, or model 1, is where palliative care was delivered by palliative care specialists who have decades of training, experience, board certification, and they are the ones who are delivering palliative care using evidence-based guidelines. And treatment B, or model 2, is our hepatologists who underwent primary palliative care training for 12 weeks. We had an online program. We can go into details for that. But those people who are already taking care of these patients. So patients with advanced liver disease, most of their care happens within the field of hepatology because that's a complex population needing specialized care. What we equipped these hepatologists was not liver knowledge. They already had it. What we equipped them with was some basic primary care palliative, primary palliative care skills on effective communication, serious illness conversation, caregiver assessment, symptom management, decision making, shared decision making, like all those beautiful 10 aspects of palliative care were integrated into their routine care to deliver these services.
How long was the training?
So the training was about 12 weeks. The training was adapted from the field of medical oncology. So I myself took the course again a decade ago. Palliative care always focused on medical oncology, offered through Stanford online program. Again, probably at that time, Coursera was free. So, you're just giving your time and effort. And this is always interesting to learn. So I did the course and I'm like, can we convert this case scenario from medical oncology to liver? Because to treat your liver specific providers, you need something which is important to them, which they care about day in and out. So we utilized some funding from our local foundation, Albert Einstein Society. Really thank you for their support, for helping us tailor the entire program from A to Z to the entire liver case scenario, which was informed by palliative care physicians, by hepatologists. There is a group of hepatologists who are much committed to integrate palliative care into their routine practice. So we identified those key members as a part of our executive committee, Dr. Volk, Dr. Navarro, Dr. Teddy. So all of them came together and we tailored the entire program, along with our research advisory board members who were patients who lived with liver, cancer or other chronic illnesses. So this training program was offered online, 12 weeks, weekly sessions with some Zoom sessions.
How many hours?
Mostly recorded sessions. About, say, 2 to 3 hours.
So
3 hours.
I'll jump in here. So there was like a pre-course knowledge survey, and then each of the modules you could spend like from 1 to 3 hours in that. And in each of the modules, there were also some active synchronous case studies and discussion groups of the case studies that we evaluated what the hepatologist thought about the case studies and the course in general. And there was really overwhelming positive feedback. Maybe because this was a tried and true course that had been done in other diseases. And, Jan D'Onofrio and Kavitha Ramchandran were leaders in doing the course, and they were sort of helped us to, specify the course or tailor the course to hepatology. Mm-hmm.
And I would just add that it includes what you would expect. There's modules on physical symptoms, psychological symptoms, spirituality, psychosocial need, communication, hospice, advanced directives, etc.
And is this, so I was emailing back and forth with Cara Bischoff, who's a researcher and clinician, palliative care doc here at UCSF. And we were saying, is this realistic? Like in the real world, outside of a study, that hepatologists would do 12 3-hour sessions? Like,
right.
They're pretty busy people. I'm like incredibly impressed they did it for this study. But like in the real world, I don't know, did that come up in the qualitative interviews? Were there people who declined to do it because there's absolutely no way they had time to do 12 3-hour training sessions?
I guess we had no declines, honestly. So, I mean, we'll go back again a decade ago when we recruited these sites. So these sites and these investigators were, not picked, but they were recruited from a group of healthcare delivery special interest group, which we have within our national organization, the AASLD, where people come together, they engage. And that's the place where we were able to identify some people who were really interested to be trained. And like, this really seems interesting. And since I think the biggest selling point was this was all liver disease specific. So whatever they are talking about really matters to them in and out. They want to help improve the quality of life of their patients. They want their patients to be satisfied. They already know. So we didn't talk too much, as I said, we didn't talk too much about the liver. We talked about how to do it, how to integrate these things into their, routine practice. And to your point, there was a mixed, as I was telling Chris in the morning too, it's like we had a wide variety of people some who said, I already do it. You know, so this is a part of our practice. I talk about symptoms, I talk about quality of life, and some are like, I don't really do it, so I would love to know. So there is a wide variety of people, and I think the training helped us level them to one standard for a clinical trial. For a trial, you need to have some sort of an intervention fidelity maintenance, and this training, along with a checklist which Marie really helped design, based on her feedback, like what are the key elements they will assess. So those things really helped bring everybody to one common point.
Go ahead, Chris.
I just want to jump in with 2 points. One is just acknowledging that I think Manisha, in the beginning, as part of preparation for the study, did incredible coalition building in a field that hasn't had much crosstalk with palliative care in the past, number one. And then number two, this is jumping into the future or sort of spin-off ideas a little bit. But to Alex's question, in the further iterations of these trainings that we've worked on, we adapted it for liver and GI fellow trainees. And then we've also adapted it for materials for the AASLD online content. And both of those were obviously updated, but also condensed. So the fellows course was condensed in terms of the length of the synchronous sessions and also the number of weeks. No, I'm forgetting if it was 6 or 8, but so yes, it is a consideration.
So that's been the focus. We are trying to condense it because now we also have learned, what is the missing part? What is the missing part in the current training program which should be filled in with these primary palliative care skills? Now, AASLD has given us the guidance document, which kind of summarizes the entire palliative care aspects in 34 pages. If someone is really interested, the homework would be to just read through them and understand it. But I think the effective communication practice is where our training program was, well suited, and people really appreciated the opportunity to undergo this training.
Just for the audience, the AASLD commissioned a clinical
What is
guidance
AASLD,
paper.
by the way?
Sorry, American Association for the Study of Liver Diseases. It's an international organization, but it's the one that's based in the U.S. It's their AHPM, AHPNA. And so they commissioned this document in 2022 to have a comprehensive palliative care sort of statement, and it included symptom management for the management of decompensated cirrhosis.
And real quick, the folks so you compared this group, hepatologists that got this 12-week training versus palliative care specialists
who got no training in liver disease.
No training in liver disease.
Which is a key point.
And what did that palliative care specialist look like? Were they physicians, nurse practitioners, nurses, social workers, pharmacists? Like, who was this palliative care specialist?
So the palliative care specialists,
Go ahead, Marie.
The palliative care specialists were both nurses, advanced practice nurses, or physicians, were the primary provider of the palliative care assessment and follow-up sessions, which were a standardized thing, but it wouldn't be anything unusual that a palliative care person wouldn't normally do in, an initial assessment and 3 follow-up visits that were done monthly.
Okay.
Yeah.
Any other team members involved besides the advanced practice nurse or the physician?
For the initial assessment, no. But then they were referred amongst the team members, as need be.
Mm-hmm. As need be, yeah. So I think that's the distinct point of this study is we did not rely on a team-based model to begin with. We're like, you can build your team if you have to. That depends on the patient. It's so individualized. If the patient needs PT, you can refer them to. But we did not require a team.
Yeah. So so you're comparing these two groups, palliative care specialists, MDs, nurse practitioners, to these trained hepatologists in palliative care over this 12-week. It was a cluster randomized controlled trial, right? Because now you've trained these hepatologists. You can't now randomize the patients. But who were the patients that you were looking at? What was the inclusion for the patients?
So the patients, I'll just kind of refer to the patient and the cluster design. So by design, it was randomization of the site. This whole center, it gets randomized to the PC arm, the palliative care specialist. So they'll see all the patients, all their follow-up, because their hepatologists did not undergo any training, just to be clear. The hepatologists at the palliative care site did not undergo any training. Only the hepatologists at the hepatology kind of randomized arm. And this training happened post-randomization. before randomization, all the centers had a clear perspective that they can be randomized to this arm or to this arm. They should be prepared to do whatever, and they were committed, fully committed. Well, we get randomized to this. But again, randomization happened, which was a thing which really sparkled ideas as to where each center would fall. But the patients enrolled were decompensated cirrhosis patients who had any of, a single episode of decompensation or more in the past 6 months. So decompensation means they had a deteriorating effect of liver disease related to ascites or development of, decompensated variceal bleed, encephalopathy and those things. Or they were liver cancer patients except stage D. So we have, we did not include very, very advanced patients because the primary endpoint was 3 months. So we wanted to make sure we have, enough patients who do not, die or other things to make sure there is enough follow-up.
I think importantly, the transplantation, maybe, Chris or Manisha, you want to comment on the criteria that related to transplantation.
So it was like we did not want to include patients who are expected to be transplanted within the next 3 months, because transplant is, a life-changing whole journey, and that needs a separate whole conversation.
There was also an exclusion, Manisha, correct me if I'm wrong, of if the hepatologist felt that the person had less than 6 months prognosis, which I think is an important point, because if you look at the composition of the study population, it's a relatively functional, a higher functional status with a relatively low, not that low, but mortality rate.
And that's the hepatologist in either group. The ones who got the control, maybe I guess palliative care specialists versus whoever their hepatologist is.
Whoever was caring for them.
Yeah.
You also excluded hospice patients or patients who are enrolled in hospice?
So finally, we did not pre-specify any criteria. The patient is going to hospice. Probably they were not included anyways, because the key exclusion was also people who received palliative care within the past 3 months.
Okay.
Any patient who to have a washout period for 3 months was considered. But in the actual analysis, we excluded people who were either transferred to hospice or received a transplant within 3 months of intervention.
I wonder if in the quest to obtain this clean sample that hadn't been contaminated by palliative care, to the extent that palliative care can be a contaminant.
Or a transplant. They had been contaminated by a transplant. Or contaminated by hospice, which is palliative care too.
Yes, right. Or had a limited prognosis. I wonder if our listeners are thinking, gosh, when our palliative care team sees patients with liver disease, that's the majority of patients they see. Patients who have limited life expectancy, who might get on the transplant, might be getting a transplant, but might not be, because they're, to get a transplant, you've got to be sick enough to get a transplant. That bumps you up the list, so you're pretty sick at that time. So maybe they co-manage those patients as well. Maybe they see patients who are enrolled in hospice. I think that's less likely. But do you worry that you could have taken the major group that sort of benefits from and in practice is seen by palliative care out of this study population?
I think that was the goal, actually, is all those people that you just described, Alex, are very near end of life. And we're talking about what one would call maybe your garden variety advanced liver disease patient who's not currently headed immediately for a transplant or not in hospice, right? And so those two groups are ones that might be likely to get more involved in palliative care. So this was like everybody else. So I'd actually describe it like the opposite way. This was like the majority of ALD patients, and we kind of cut off the edges of people who were sort of near death or headed down a curative road.
It's very helpful.
I mean, how often do you see somebody in outpatient palliative care routinely who has advanced cirrhosis, but their MELD is low? Very, very rare, at least for me. You mentioned the issue of contamination. I just have a sort of anecdote. I got involved in this study at one of our affiliates, which Crystal Hunt's the hepatologist there. She invited me knowing that I was very interested in palliative care for liver disease, and we were going to be a site for the study. And I helped with the grant and the hiring and the study startup at my site, and then they got randomized to the hepatologist arm. And I was like, all right, well, it was nice knowing you guys. Because I was like, I can't come and contaminate this. But I guess a lesson for early career me, showing up is so critical for this work and for success, I think, in what we do. And so I kind of just kept showing up at the larger meetings for the steering committee. And, you do that enough and not be annoying and be helpful and end up on committees and,
Chris,
So
you were
anyway.
very helpful. Very helpful, and actually we became very good friends. So Chris is a part
Yes.
of our
Okay.
Palliative team. Yeah.
I got another question. I got two questions about the methods, and we'll go into the results. First is you did a modified intention to treat, and then that modified you excluded. We talked about transplant patients, but also hospice patients, people who transitioned to hospice before 3-month assessment. Why? Because I feel like an important part of palliative care consults is also knowing when to refer to hospice and talking about hospice. I mean, that's something that's important that we do. Why exclude that from the analysis or from the modified intention to treat?
So I'll take the response. I think since it was mainly the effect of the hepatologist's intervention, for the first 3 months, that's the primary endpoint. And you cannot allow contamination when the patient is in hospice. The entire care is, all hospice palliative care providers. So it was very difficult for the hepatologist to even intervene into the care planning at all. So
But
I
isn't
think
that
we
part of palliative care training, like knowing when to refer somebody to hospice?
Isn't that a post hoc thing that couldn't be known in advance?
And it's one of our interventions that we do, and isn't an important outcome to like why remove those patients, because it is part of our armamentarium.
I think it was a very small number. It was a very small.
It didn't actually
It's
influence anything.
It's only 17 patients, 10 in the consultative PCR and 7 in the hepatologist arm who were transferred to hospice.
Okay,
But
so there's no big
pre-specified-
difference there.
No big difference.
All right, I'm going to take that away then. My second is that you had some ways a statistical squeeze here. You had COVID, which I understand hit, again, 10-year study, and you had to decrease the sample size. But then you also switched to an interesting framework where you first assessed for superiority. Was hepatology one better than the palliative care specialist one? And then if it didn't meet superiority outcomes, you switched to non-inferiority framework, which was not planned at the start, but somewhere during the middle of the study, you added the non-inferiority, which, like, if this was a drug and I saw pharma do this, I would be like, ew, that's a big no-no, because if you add something like non-inferiority, now your non-inferior margins are super susceptible to bias. Like, I'm going to choose a non-inferiority margin that I think will work. And that also significantly changes how you think about sample size calculations. So tell me how that happened and why you did that.
Yeah. So maybe I'll tell you a little story. PCORI built a PCORI learning network, PCORI Palliative Care, PCLN, Palliative Care Learning Network, which comprised of 8 large studies, which PCORI invested almost $80 million into this funding announcement, including Jennifer Tamel, including Corita, from New York. There's 8 to 9 funded studies. So as a part of the Palliative Care Learning Network, they put together a team of biostatisticians to discuss about, what kind of analysis should go in. Me being very naive, we attended and we worked with Duke, Dr. Andrei Kusinski as our key statistician lead. He is a key part of this kind of decision making as the statistical expert. So we attend the meeting and everybody was like, what if the superiority fails? Again, this is a meeting which is for learning, for exploring what are the best way or put your foot forward, particularly during COVID. These meetings happened virtually.
Yeah.
And during those times, there was a brilliant idea from some of the like-minded statisticians that there is a way you can inbuilt a non-inferiority to, again, not to demonstrate that one is non-inferior, but to actually keep your study's integrity intact. So we thought, here we are. I would recognize this is tough. Having a hepatologist deliver palliative care is tough. It's a lot of time issues, which I'm sure Marie will talk from our qualitative interviews. They liked it, but there was a lot of other competing priorities, and there were things which were not going right at some places. So we added this non-inferiority during the trial design, but without any outcomes data. None of the investigators, not even the statistician himself. So since we worked with Duke, I think they had a very rigorous system of blinded versus unblinded statisticians. Very rigorous. I mean, they really follow the protocols. I had no access to any outcomes data, neither did Andre. So we really designed this non-inferiority hypothesis during the design, during the trial conduct, prior to any sort of unblinding, as a framework to assess whether hepatologists delivered palliative care could achieve outcomes which were comparable to specialty palliative care. And this approach was really motivated by feasibility and implementation considerations. And also, I'll just like to highlight that non-inferiority still had a non-inferiority margin of at least 4 points. And those 4 points were based on Dr. Tamel's trial on palliative care in lung cancer patients.
Says it's half of the minimal clinically important difference for the quality of life instrument.
Yeah. And none of the interim data analysis informed this. This was merely, an open-ended discussion which brought back home some ideas. It's like, what if? Everybody's fearful. What if this doesn't go? Then having an inbuilt mechanism. So I'm really thankful to all these statistical methods to make sure we have this concept, which is new.
So what did you actually find?
There was almost a 7-point improvement in the palliative care arm in quality of life, which is our primary outcome from baseline to 3 months. An 8-point improvement, adjusted change in the hepatologist arm from baseline to 3 months. Superiority-wise, the P was non-significant. However, based on our predetermined, non-inferiority margin, the statistical significance was strong for the non-inferiority hypothesis, which still means the hepatologists did a little bit better, and they're comparable to the palliative care specialists. But again, I'll just like to, highlight one thing here. We are not comparing, providers. We are really comparing the two models. We are really comparing the implementation aspects of both these models, and both are equally good. That's the real outcome.
And you just said the hepatologist did a little bit better. Could you finish that sentence? Then did a little bit better
than the palliative care model.
Than the palliative care specialist.
But
was there a statistically a difference between them?
No. There was the non-inferiority P was 0.01, and the adjusted mean difference is about 1.
Does that mean that there was a statistically significant difference in the
or non-inferiority? So for equivalence, to demonstrate that there was equivalence between the models. So the first test, which was the superiority of hepatologists, was not statistically significant. And so then they went and looked at were the inferiority hypothesis, and that was statistically significant, kind of a double negative. So non-inferiority, it shows that they were not inferior to each other. Does that make sense?
They were equivalent, which means that they fell within inside that non-inferiority margin, whatever margin that you could put.
That's what I take away from it, that they were equivalent, not that the hepatologists were doing better than the palliative care specialists.
They had a numerically...
Is that fair, Manisha, to change that sentence?
Sorry.
Okay, thank you. Yeah.
And they had a numerically larger improvement, but they actually started at different... The hepatologist group, I think, had a worse quality of life score at the start. Is that right?
Correct. That is true. There was a slightly, it was controlled for in the final analysis. It was adjusted.
Yeah.
But the hepatologist group had a worse quality of life to begin with.
Yeah. Which is also, I guess, one other critique of this article, which is, if you have to adjust for something in a randomized controlled trial, how good was the randomization? I did notice that the number of patients in the hepatology group was significantly less. No, I wouldn't say significantly. It was less than the number of patients in the palliative care specialist group. Any idea why that was the case?
Yeah. I think, again, it would go back to those 5 years. We monitored enrollment every single month. There are two kind of things which are not written in the published article. And one is, of course, there is randomization, but then there is, every site has their own research operations. We found there were at least 4 or 5 strong research operations sites, which were in the consultative palliative care arm. They were enrolling every single month. But here is the hepatologist group struggling to recruit coordinator, or there is more staff turnover. We are looking for more staff, there is staff training. The study coordinators actually were the key component of this.
Do you think that could have
patients.
influenced results at all? How's that for anybody?
I think that's I don't think the outcomes would have been influenced by that. The number of patients are still comparable. There is no statistically significant difference at baseline among these two. So I think the results would still be the same. It is just the implementation methods, which, every site had to do their own. I cannot create a room for a hepatologist site because they don't have enough room for doing this intervention. Now, we had a site where this was a problem. Yeah.
Okay, Chris, I'm going to turn to you. Are you doing anything different with the results of this study?
Oh, like in terms of changing practice?
Yeah, should we do anything different with the results of the study?
Well, okay. So before we knew what they were, I would always sort of think, I wonder what it's going to be. And I worried that if it came out one way, that hepatologists were, superior, that people would say, well, then why on earth would we embed palliative care in our practice or refer people to outpatient or whatever? If the opposite were true, I would worry that people would say, well, why are we bothering spending our time doing these modules and owning some of this care?
Just give it to palliative care.
Yeah, we can just refer out, which we all know, obviously, for 100 reasons, isn't always easy. And then, so in some ways, the fact that we have this non-inferiority finding is interesting because a question begets a question, right? So now it's like, well, what are the implementation questions? What are the factors in one health system versus another that might promote success of one model's implementation over another based on preferences, structural, systemic, all the things. So for me, that's a huge takeaway.
Yeah. I think another implementation, what you were talking about, Chris, challenge, came out in the qualitative data when we asked hepatologists, what was it like doing this type of care? What did you do differently? How was it like talking to, and we asked palliative care people, of course, the same question. We also asked hepatologists what they thought of the training, and they universally loved the training. Some of them loved role play, some of them hated it, but overall, there was the hepatologists really loved the training. And we've got actually 3 papers where it talks about what they thought about the training. But, getting back to the implications of it, they pretty much said the same things with a slight nuance. So the hepatologists were like, the amount of time that this takes is really a lot more than the way I would usually do care, but it was really worth it. And the reason it was really worth it is because it improved their relationships, their communication. A huge finding was they had never talked to caregivers before. I say never kind of in, hyperbole, but they hadn't talked to caregivers before. Now, because of the study, they were forced to talk to caregivers. And they're like, wow. And one of them actually said, I really feel like I've neglected caregivers to this point because I just never even thought of talking, but it's so valuable. The caregiver piece was overwhelmingly described in all the hepatology clinicians. Like, this is so important. Like, they just discovered it. Interestingly, the palliative care people, like, they never talked about caregivers because routinely we're seeing caregivers, right? It's part of the unit of care, right? And so it was very interesting, that real dichotomy between hepatologists discovered caregivers and palliative care didn't think anything of the caregiver piece of it because they do it all the time anyway. So that the timing piece and the caregiver piece were 2 things that really came out in terms of practical implementation going forward. The hepatologists, they used to book their study patients when there was no other patient following them. So they had plenty of time at the end of the day. or on a non-clinic day. Like they'd see their research patients on a non-clinic day, so they weren't wedged in the time. And so that was a huge issue. And the palliative care clinicians reflected on time and said, I think it's great, but I don't know where they're going to find the time to do this. Sort of going forward outside of the study. So those were two really big, reflections.
Let me ask you about that then. So you have a busy hepatologist who makes a lot more than a palliative care doctor. Palliative care doctor can generally book a little bit longer visits. The hepatologist has like 13 million other things to do. Like if you were to design a system knowing the results of these studies, let's imagine we all agree, one's not better than the other. They're equivalent, at least within this non-inferiority margin. Why not just choose the cheaper one and have the hepatologist do all the hepatology stuff that they got to do?
Well, is it cheaper? Because we need space.
Really.
Yeah, we need space. It's an opportunity. If you could put a proceduralist in the room that I'm using, you might make more.
But I just also heard the hepatologists had to schedule these patients on a day where they had more time. In real life, like what would this look like outside of the study? Is the system is perfectly designed for the results it gets, and we see this kind of over and over. Is like I was the worst palliative care doctor when I was attending on the wards. I was doing both. Like 1 week I'd be palliative care, 1 week I'd attend on the wards. The second I hit the wards, my palliative care doctor disappeared. And that's because you are focused on so many other things.
Mm-hmm.
I think what we also learned, through personal conversations and through a qualitative input was also experience over time. We all go through kindergarten and then through high school. I know I talk about school a lot. That's the place I love. But, when you were doing these conversations, people were saying they were taking longer during year one. However, over time, they became quicker at it. Mm-hmm. I could do this much more quicker. I know how to bill it, code it, use the G22 modifier. We had individual conversations with some of those hepatologists post-study to see how it is now part of their practice. Some people are still doing it. And I'm really hoping we will do a follow-up survey and qualitative interviews with these hepatologists after 1 year of PAMLiver. How much did you actually take it to your routine practice? So we are still, I think, if you really value your patients, quality of life, and you want to make sure it is getting better, people are making time. And they are getting good at it once they have learned the skills and practiced over some time. The skill set becomes much more advanced.
Yeah.
I would also add, perhaps most importantly, that we also see, and this is not published yet, but under review, the patients valued the time too. The patient and the family, and the family caregivers. In both arms, there's data from the interviews where people say, I really appreciated the extra time. I felt listened to. I felt like I had access to the team, etc.
There was always someone there whenever I needed somebody, which was a very different experience than they had previously. They were like my friend, they would say. Like they would answer whenever I called. It was really amazing to hear the patient and caregiver results. And, we're really sort of putting a teaser out there for when the full paper comes out. But, that was really a major thing. And so I think there was this really synergistic thing where the clinicians felt more satisfied and the patients definitely felt more satisfied. And together, they were happy.
Yeah.
And since satisfaction is the goal, I'll just add one more thing. Since satisfaction is the goal for many healthcare systems to achieve, this is something which they can adapt. Now, this intervention is going to help you satisfy your patients, improve your satisfaction scores and cascading scores. So why not adapt it? I think these are, again, plannings are steps for making it forward. And we don't want this intervention to wait for 17 years to be implemented into routine practice. And we want to cover up with some implementation gaps. I think really excited to see where we go next.
So what would if you had a magic wand, last question for all three of you, what would that implementation look like? Like what would you use that magic wand on knowing the results of this study? Manisha, I'll go to you first.
Okay. What I would think is, if I had access to 10 healthcare systems CEOs,
Yeah.
they're just sitting next to me and very
Yeah.
friendly and ready to talk.
It's a magic wand. You can do anything right now.
So they're like, okay, here, Mr. CEO, there you have two choices. Model one, the consultative palliative care arm. We are going to give you the tools. We're going to give you the checklist and list of criteria so you can focus on early palliative care for these earlier stage patients so they have a better quality of life over time. And here's, we can train your hepatologists and gastroenterologists probably in your network and save you your palliative care resources for your cancerous and seriously ill patients who really need that specialist service.
Yeah.
Can you train your providers here and use these implementation strategies to adapt the models?
Chris.
I would take a small palliative care team that's multi-professional to function as champions and also clinicians to provide, longitudinal interaction, liaising between the departments, maintaining ongoing education of both groups, and then figure out in that setting, what are the facilitators of referral between the trained hepatologists and the specialists?
So you're doing a little bit of
It's
both.
gonna look different. A little bit of both. And, they got to figure out what is the slot length that you're going to do? What is a new appointment? What's a follow-up, et cetera. So
Marie, last one, magic wand.
Magic wand, we just take the time, money continuum out of the picture and just let people do a really good job of what it is that they enjoy doing.
Wonderful. How about Alex enjoys singing? Maybe you can do a little bit more ABBA. What's the song titled again, Manisha?
It was the Slipping Through My Fingers.
Great. Alex?
Slipping through my fingers all the time, I try to capture every minute, feeling in it. Slipping through my fingers all the time, do I really see what's in her mind? Each time I think I'm close to knowing, she keeps on growing. Slipping through my fingers all the time.
Chris, Manisha, Marie, thank you for joining us on this Jerry Pal podcast.
Thanks,
Thank you,
Eric
Alex.
and Alex.
Yeah, I would just like to thank and express gratitude to the entire Palliative team. It was not a single person's job.
Yeah.
It was a huge team of collaborators. And the leadership of Dr. Victor Navarro, who has been my mentor for more than a decade, couldn't have done it without him. And above all, the PCORI's program officer, Dr. Neeraj Arora, and his team. And they were so supportive of each and every step we took. It was not an easy journey. Through the 6 years of this trial to meet the enrollment goals and make sure everything is working, and above all, our research advisory board. Really, I think every element of this trial is patient-centered and patient-focused, and really want to thank the entire team for the success.
Well, thank you for that. And I'd also like to say thank you to our listeners for your continued support. We'd also like to do a big shout out to those who've donated more than $250 in the last year, including
Carrie Levy, Marnie Feltzer, Ron Sabar, Stephanie Gabatuller, Patrick Lally, Richard Lewis, Margaret Leung, Cindy Harris in honor of Emily Guillot, April Sear, Anna Naik, Sudha Chandrasekhar, Michelle Reisner, Asher Edwards, Susan Nelson, Rebecca Goldstein, Rochelle Bernacki, Carol Dietrich, Mark Andrews Wren, Elizabeth Cobbs, Amy Rock, Meg Walhagen, Xinyi Wang, Sharon Bragman, James Tulsky and Yana Saraf, Kelly Strait, Michael Bordowski, Jessica McFarland, Gretchen Schwarzy and Joshua Mesrich, Rob Razak, Diane Meyer and Sean Morrison, Elizabeth Chung, the John A. Hartford Foundation, Lloyd Woolstat, Harry Hahn, Bob Arnold, Ginger Robbins, Matt Schuster, Maureen Kearney, and Kenny Lamb.
Thank you.